All right. So last time we discussed the cestodes, like for example, Tenia species as well as Diphyllobotrium caninum. These are the two types of cestodes or the tapeworms. So the infection, the tissue infections are associated with their stage. The stage including the cysticercosis or the cysticercus, spalchinosis, as well as hydrotic cyst disease. These are the major disease caused by the tissue stage of tapeworms. Of course, they originate when human accidentally become infected with these cestodes and acts as intermediate host for the parasites. So cysticercosis result when human ingest, of course, infective egg of Taenia sorium, of course, the pork tapeworm, and then the human is then becoming an intermediate host. And the contributing factor for infection, of course, include poor hygiene as well as sanitary habits. And once egg is ingested, the hexacant embryo within the egg, because this egg will be embryonated, so the hexacant embryo is released into the intestine of human, and then it is able to penetrate the wall of the intestine, then enter the circulation to develop to a cysticercus, so in any tissue or organ of the body. So the larvae can live up to 7 years, and then will cause the tissue reactions, which of course result in the production of fibrous capsule in tissues. So that is a capsule which is fibrous that will develop in tissues because of host reaction. So once the organism dies and there is larvae antigen, there is intense host inflammatory reaction that could lead to tissue damage of that area which is infected. So even, of course, you'll be able to see calcification of the cysticercus in the area. So the most common infected sites are, of course, with this cysticercosis will include striated muscle, the eye, and then the brain. Even though sometimes symptoms are not apparent with light infections, but symptoms when they occur, it depends on organ affected as well as the size and number of cysticerci present in the tissue. So muscular pain, weakness, as well as cramps will actually be a characteristic of infection in striated muscles. But of course, even sometimes retinal detachment, especially when the retina is affected, as well as intraorbital pains, flashes of light in the eye, as well as blurred vision, will also occur in case of what we call retinal cysticercus or vitreous humor cysticercosis. So neurocysticercosis, which occur, of course, in the brain or the central nervous system, it is the most serious infection, of course, and the manifestation include headache and the other symptoms that you'll also notice. Those symptoms resembling meningitis and sometimes even a brain tumor, convulsions, or even motor and sensory problems. So cysticercus is just oval, translucent, and it contains invaginated scorex, which contains at least 4 suckers and even hooklets on the rostrum of the scolex. The infection may be diagnosed by various methods, of course, including radiography to detect calcified cyst, as well as, of course, eye examination, which is ophthalmoscopic examination in order to detect any infection of the eye. Of course, sometimes even CT scan and MRI in order to locate larvae in the brain, as well as, of course, biopsy and histologic staining of tissues. Apart from cysticercosis that is caused by Taenia, especially Taenia sorium, the spalganosis is infection of peroxycoid larvae. Of course, you know what you call peroxycoid larvae. It is in a larvae of Diphyllobotrium caninum, which results in spalganosis. So human will just acquire this infection by ingesting copepods. You remember copepod that contains peroxycoid larvae of the Diphyllobotrium caninum, and sometimes even ingesting reptiles, amphibians, or other animals containing these larvae. So the disease is most common in Southeast Asia, of course, but what happens is that there will be migratory subcutaneous nodules, and which is accompanied by itching and pain, of course. And the diagnosis of these plerocercoid larvae is made by finding small white Liban-like organism and with the rudimentary skull eggs, of course, in tissues. So size vary, and you can actually remove these organisms surgically, of course, in the infected tissues. The last tissue infection of the cestodes is echinococcus. Echinococcus is it causes infection which is called echinococcosis, which is hereditary disease with the organism Echinococcus gandrosus, which has got actually a definitive host as dog, but human, of course, will act as intermediate host, and adults will just have at least 3 proglottids. It is a very short one, and it is actually about 5 millimeter long, and the eggs are found in feces of dog, and of course, and those eggs will just resemble the egg of Tenia species. So for humans, of course, as usual, here humans become intermediate hosts by accidentally ingesting the egg of the Echinococcus gandrosus, which contain the embryo, because even the egg is embryonated. You find the result you call hexacant embryo that is found within the egg. So then, of course, the same mechanism that this embryo will just migrate to the tissues, whether it establish tissue cystic disease. The second group of organism is, of course, what we call roundworms, and roundworms are those we have got some intestinal roundworms as well as blood and tissue roundworms, and most commonly, and most of these infections, most of these organisms, the transmission is by ingesting the embryonated egg. For example, of course, Ascaris lumbricoid, that is a intestinal tract roundworm, and the infection is just by ingesting the embryonated egg or by just direct penetration of the skin by the larvae in the soil, and they require insect vectors, some of them. So these are the different roundworms, and roundworms, they are not hermaphroditic. They will possess at least 2 sexes, and the life cycle will involve larvae migration throughout the body. Just a classic example is like Ascaris lumbricoids. So larvae of the Ascaris lumbricoids migrate throughout the body, and the adult is just being nourished by absorbing nutrients from partly digested intestinal contents, and sometimes by sucking blood. So in most cases of roundworms, we find that the symptoms will just vary depending on the worm burden and host nutritional status and age, and even duration of infection will also predict the symptoms or presence of symptoms. The first roundworm is Enterobius vermicularis. So Enterobius vermicularis is a roundworm, but also we call it a pinworm, and it is normally it is a common infection in children, especially those children in between 5 to 10 years of age. And the egg of Enterobius vermicularis, of course, is very resistant to drying, and they can be easily spread in the environment, and even adult worm can live in the intestine, especially in the cecum, and it can also sometimes be found in the appendix of the intestine, sometimes even in the vagina. So ectopic infection can also occur. That is, of course, infection outside the usual part of the infection, the usual part of the body. That is unusual parts, which include endometrium as well as urethra, and also the fallopian tube, which can cause salpingitis, of course, and also endometritis, that is endometrium of the uterus, as well as urethritis. So even in some cases, Enterobius vermicularis can be associated with the urinary tract infections in young girls. So because it can normally affect the urethra especially in women. Even though the infection of this vermicularis is really asymptomatic, but patient will even experience loss of appetite, abdominal pain, loss of sleep, nausea, and vomiting. But the main symptom is especially these infected people experience. It is what we call anal pruritus, which is associated with the migration of the female worm to the perianal area in order to lay eggs. So when this female worm is migrating to this area, patient experience pruritus. So life cycle is just very simple. It's very simple. It is just it is characterized by the migration of the female worm out of the vagina at night to lay eggs in the perianal area, and to the anus in order to lay eggs in the perianal area, and the eggs are infective with the third stage larvae within several hours after being laid. So this egg can be infective, and transmission can involve the inhalation of the eggs, ingestion of the eggs as well, because these eggs are very small. You can there's sometimes they can be airborne, and even direct and oral transmission is caused by poor hand washing or fingernail biting, which is normally very common in children. So don't allow children biting their finger, and even maybe biting or sucking their thumbs. So that is very risky, because that can promote the direct and oral routes, and even from their fellow children. So autoinfection is also very common, especially in which the hatched larvae can re-enter the intestine to mature and become adults. Because eggs are laid outside the body, so then in the perianal area, and they are rarely present in the stool, fecal specimen is not satisfactory for diagnosis. So we don't prefer a fecal specimen or stool sample. It is not really good specimen for diagnosis, but cellophane tape preparation is very important in order to assess or to examine and to find this to diagnose this infection, especially which is available: sticky paddle, which is considered as the methods of choice. Of course, the procedure must be done as soon as the child arrives in the morning, and the perianal area is then touched with the sticky sides of the tape. Then, of course, adult female can be even seen here in the preparation, but the main purpose is to correct the laid eggs in the perianal area. And because the gravid female can migrate into the vagina, sometimes eggs can also be seen in vaginal specimens, especially vaginal smear, or vaginal swab. And adult female can actually possess long pointed tail and 3 autical lips with a lay at the interior ends of this female. So sometimes they will even present with male, which are characterized by curved posterior. Even ascaris are the same. They will have curved posterior, which is of course a reproductive organ of this male worm. But the eggs can become very important diagnostic stage here. Eggs are just small, very small, but oval and colorless, and sometimes they can have flattened on one side. They can be flattened on one side, and in most cases they are seen embryonated because of male and female egg, so they can fertilize, and then female will lay embryonated egg, sometimes with the C-shaped larvae. Larvae is almost C-shaped, but as you can see, this is just egg of Anthrobius vermicularis. It's very small and oval and colorless, and even you can see the embryo inside. But most commonly with the one side flattened, like you can see this side here, it is actually particularly flattened. If you look at this, it is actually flat. So the second roundworm is a Trichuras trichura. This is the second roundworm, Trichuras trichura, which is also called Trichuras or trichocephal. That one is also very common, especially in French. So Ascaris rhombicoides, as well as Trichuris trichura, there are two genera of hookworm and two genera of hookworms, of course. Ankylostoma and Necator are all soil transmitted helminths. So we have all these roundworms that are soil transmitted helminths. Those include Ascaris lumbricoides, Trichiura, as well as other hookworms. So hookworms are also part of roundworms. Those are Ankylostoma and Necator americanus. So these organisms that are worldwide distributed, and of course, they are the major cause of morbidity rather than mortality in developing area of the world. So they don't then actually cause a serious morbidity, but not really mortality in this area. But even mortality, but not they cause mostly morbidity. So chronic infection caused by these helminths, of course, especially hookworms, can normally affect the physical and mental development of children, and even heavy burden can be a very serious issue. So for example, Trichiura, which is called the whipworm in other words, it is found in moist and warm climates of the world. So sometimes it is not associated with the infection with the symptoms if the infection is very light, and if the infection is very heavy, then you find intestinal bleeding, weight loss, abdominal pains, nausea and vomiting, as well as chronic diarrhea when the Trichiura infection is very heavy. So, but otherwise, even adults will experience adult worms will just thread themselves through the intestinal mucosa, which can cause inflammation in some cases. So when the infection is very prolonged, it can even cause inflammation of the colon, which is called colitis, as well as diarrhea. And also you find that there is blood tinged stool in some cases, like some blood on the stool, but not really blood diarrhea. So in some cases, even with the heavy infection, there would be rectal prolapse, and most commonly in children. So hypochromic anemia will happen because this infection is this parasite is actually also ingesting blood, and even this low bleeding problem because of inflammation. It can also, or even sometimes colitis. Colitis associated with the low level of bleeding, but which is a very chronic. So this can lead to a chronic anemia, which is hypochromic at the end of the day. That's what happened. So then eggs can be passed in the feces, and of course in at least 14 days in warm, moist soil, they can embryonate, and human will acquire infection by ingesting the infected eggs. Of course, effective eggs are those ones that are embryonated eggs, and when they are raised in the small intestine, they can undergo several molts before they can mature into the adult worms. So those are the larvae from those effective eggs. They can mature in different molts, and then they will become adult worms in the cecum of the intestine. So, but sometimes even the eggs and occasionally the adults of these parasites can be even seen in fecal specimen, even adults of the Trichiura. So adult male will have thin anterior and thick coiled posterior ends, and female they would have thin anterior and thick straight posterior. So they are also curved or coiled for the male, because as you remember, that is just a productive area of the male on the male. But of course, always female are longer than male, but they will be straight rather than being coiled or curved at the end or the posterior part of it. So brown and bell-shaped eggs will be seen, and sometimes when they are passed, there's no embryo yet. They are not embryonated. So, but of course, they may be fertilized, but not embryonated. You find them with a thick wall and the hyaline polar plugs at each end. So Trichiura eggs are very, very prominent. You can be able to recognize them very easily because of the polar plugs. You can see the plugs, one plug and another plug here, ends plug, and even thick walled. And you can see this egg is you can find larvae, but of course the eggs got fertilized before it was passed. So the next one is apart from the Stichuris, which is characterized by this bell-shaped egg with the posterior and anterior plugs, right? Let's look at the Ascaris rhombricoids, of course, which is also another roundworm, and the primary transmission is of course by fecal-oral route, and the organism is found concurrently, most commonly with the Tritura. Sometimes it is not uncommon to find the Ascaris together with Tritura, which is also called whipworm. So abdominal discomfort and loss of appetite and colic pains will occur with the presence of adults in the intestine. And of course, with the heavy infection, we can find sometimes lactose intolerance and even malabsorption of vitamins, including vitamin A, with the children, especially children with heavy infection. So children, they will have even intestinal obstruction in case of heavy infections, and because the worms can feed on liquid intestinal contents, you find that even children are suffering from malnutrition, which may hamper growth and development of children. So larvae migration throughout lungs can cause other problems, for example, asthma and edema, and as well as pneumonitis and eosinophilic infiltrations. Especially eosinophilic infiltration in the lungs can cause serious inflammation in the lungs. And sometimes adult worms can even exhibit exit through the mouth, tear ducts of the eye, as well as nose. And sometimes they can be seen blocking catheters. In this case now, during migration, eosinophilia is also very serious. So in most cases, eggs are deposited in warm, moist soil and become infective within 2 weeks. That's when people ingest, or children ingest eggs, and upon ingesting eggs, larvae will just hatch in the duodenum, and then followed by penetration of the larvae in the intestine wall, and then larvae will gain access to the hepatic portal circulation, which we call portal veins, and they break out from the capillaries into the lungs, which will then travel up the bronchial tree and then trachea and then over the epiglottis. So when they reach this area, they will be swallowed, and even they can be swallowed, and of course maturation is going to be completed in intestine. So which explain the idea that these worms, roundworms, are migratory worms. They like to migrate, especially when they are still larvae. So they cannot they migrate most commonly when they are still larvae. So they just migrate across the body through blood, but they eventually return back to their habitat, which is intestine. So when you're finding the eggs, eggs can just act as diagnostic stage of these worms. Of course, you find that fertilized Ascaris egg are just oval, and you find they have thick hyaline wall surrounding in one cell stage embryo, and most eggs, they have brown bile stains mammillated out layer. So this is the diagnostic stage of the Ascaris, which is egg. So egg of the Ascaris, especially the fertile egg, which is unstained, will have a double embryo, as well as, of course, double wall, which is thick hyaline wall, and the egg is oval and with the mammillated outer layer of the egg. So these some eggs also, they are called decorticated egg, which lack mammillated outcoats. So those eggs, that are infertile eggs which are elongated, somehow elongated, and contain mass of highly refractory granules within the eggs, but this egg is not really embryonated. So they are called decorticated egg, and they don't have what you call mammillated outlayer of the wall. So like this one, you can see the decorticated egg of the Ascaris rhombricoids. It does not have a thick wall and even the mammillated wall is not present at the outer surface of the egg here. So this is what we call the corticated egg. Of course, in case you want to examine also adult worms, like most commonly this is done macroscopically, you can be able to see the worm with your eyes. The egg has a diameter of a pencil and may be found in stool sample. So for female, they look straight. They will have straight posterior ends, as well as male with the curved posterior ends, and both they have three anterior lips with small tooth-like projections projecting from the anterior part of the worm. So that's how you could be able to identify ascaris. But that's pretty easy to identify ascaris because they are normally roundworms with like almost the size of diameter of a pencil, lead pencil, and you find that male has got a curved posterior, but female with a straight posterior. So female is just straight, is never curved at all. Yeah, I think you have seen them, how they look like. Okay, so finally we have I don't think it is final, but you have hookworms, of course. Hookworms, these are the worms where you find the hookworms like Ankylostoma and also Necatol americanus. These are the two species of hookworms. So Necatol americanus is called New World hookworm. Of course, you know that they sometimes consider America as a New World. So, but of course, Ankylostoma has got Old World because probably that's found maybe in Africa, because Africa is also an old continent. So call them Old World hookworm. So it is not easy actually to differentiate these two worms, but of course we can just the two species can be differentiated by the morphology of the buccal capsule, or sometimes in male the copulatory balsa of the two can be used to differentiate. The eggs will be very, very identical. So these worms live in the small intestine and they attach the mucosa by means of teeth, especially the Ankylostoma duodenal. It will just attach on the mucosa by the means of teeth, but cutting plates are associated with the Necatol americanus. So they can digest the tissue plug. They digest the tissue plug and Pes capillaris, of course, Pes capillaris of the intestine. Once attached, they then continue to ingest blood, and of course, blood is a source of their nutrients for them to survive. So, some of the clinical manifestations that we associated with these hookworms, of course, we find that there's also in accordance to the phase of life cycle as well as the worm burden, which also determines clinical symptoms. So, but those symptoms sometimes include small red itchy purple, which is called grounded itch, which develop when the egg when the larvae penetrate, because these eggs, the hookworms infection is a source of infection is not ingesting the egg, but it is skin penetration of the larvae. If a large number of larvae are present during the lung phase of the migration, the patient may experience even bronchitis, but unlike with the Ascaris larvae, no host sensitization occurs in this case of migration. So depending on the adult burden, manifestation will be severe, including diarrhea, a fever, and nausea and vomiting, and eosinophilia is sometimes present in this case. So, and you find that a few patients may even experience picker and they ingest dirty, which is called the geophagia. This is a symptom. This is a symptom of a symptom of anemia or even iron deficiency during this infection, because Ankylostoma and Necatol, they will feed on blood. So for a long time or chronic feeding on blood, that can lead to iron deficiency, anemia, and often patients are actually experiencing pica, which is ingesting the dirty or soil, whatever, that is a sign of anemia. So blood loss can occur, and of course this can lead to microcytic hypochromic anemia, especially in children. They will experience this type of anemia. So treatment with these hookworms, of course, include albendazole and mebendazole, and supportive therapy, which include, of course, iron and protein supplements, because these patients are losing. So life cycle is very simple comparing with others. Of course, these include egg, which is deposited in warm, moist soil, and the egg is not infective. But feeding, so first stage labidiform larvae will just develop in 2 days and feeds on bacteria in the soil. So in an feeding infective filariform larvae, you just develop 1 week later. This is what happened. But human, they will come in contact with those infective filariform larvae. So filariform larvae, which will penetrate the skin, and the organism or this larvae will just enter blood circulation until they break out of the capillaries into the lungs and then migrate up the bronchial tree over the epiglottis, as then finally into the digestive tract by, of course, swallowing. You also swallow them. So which actually also explains the idea that all the roundworms are characterized by migration, especially migration through bloodstream and then to the lungs and back to the intestines. After additional larvae molts, there will be developments of adult worm, which will attach in the small intestine. So lab diagnosis, especially for these hookworms, it is not easy to see a hookworm in the stool, but egg and larvae, labdiform especially, can be seen, and those are diagnostic stage for these hookworms. And eggs, labdiform larvae, of the two species are not distinguishable. So in fact, when you see a hookworm egg, you just report it as a hookworm egg. Don't actually separate. Don't say I have seen Ankylostoma duodenale or I have seen Necatora americanus. Yes, so you just report you have seen a labdiform larvae or just egg of the hookworm. When you see egg, it is normally oval, sometimes colorless and thin-shelled, and it contains embryo in the 4 to 8 cell stage of cleavage. So you find those are the cleavage, especially 8. You find that there are normally 8 cleavage of the embryo. You find like this. So you can see this, like the internal embryo of this egg has got at least 8 cleavages, right? 8 cleavages when you count them in the embryo. So this is the egg of the hookworm, but not really the egg of the Necator or Ankylostoma, because they are not distinguishable. So, and also larvae, when you see them, especially the labdiform larvae, must be differentiated from the larvae of the Strongyloides stericularis, because the treatment is different. But also you remember that the Strongyloides stericularis, they will also possess the labdiform larvae stage of the parasites. The hookworm labdiform larvae will be actually around 300 micrometer long, and they will possess a very small, inconspicuous genital primordium and long buccal capsule. So these are very, very, very important characteristics of labdiform larvae of these hookworms: small, inconspicuous genital primordium and long buccal capsule. So which I'm going to show you where they are located. So, but filariform larvae also, they must be distinguished from Strongyloides stericularis as well. So hookworm filariform larvae is just about 500 micrometer long, and with a pointed tail, and even esophageal intestinal ratio, which is 1:4. That is esophageal intestinal ratio, which means it is 1/4 the esophagus to the intestine length, right? And they will have a bit of a pointed tail on them. So this is the labdiform larvae of a hookworm with a long buccal. This is what you call a long buccal capsule. This one is called buccal capsule, just like mouth, back opening. This is buccal capsule, and then they don't have primordium. So I'll show you where primordium located. They are normally located here, just around this area here. They are called genital primordium. So, but you can see also when you use the iodine stain, you could see also how it would look like with the very long. You can see where it is starting from here to this all the way. This one, this is a buccal cavity or a buccal, buccal capsule that you would also see in there. But you can see now, comparing to the strongyloid stericolaris, I tried to bring it here because I just not to confuse you when you're trying to compare with the labdutiform larvae of strongyloid stericolaris. You can see the genital primordium is very long here and it's very prominent, right? Very prominent. As you can see, this is what you call genital primordium, which is not seen with sometimes in exam they bring pictures when it comes to a part of parasitology diagnosis. Of course, they also bring some questions about clinical manifestations, lab diagnosis procedures, symptoms, infection transmissions, life cycle, and so on. But also remember, and they usually like also to bring some of the pictures. Even though they bring just 3 or 4 pictures in parasitology, that is enough. If you are able to make it, that is okay with you, because parasitology is a part of microbiology, so you don't expect even more than 5 questions from parasitology, or even 7, not even up to 7. I think like 5. So it can't be more than 5 probably, and most of them you see pictures because they want to assess if you know lab diagnosis, how to differentiate between diagnostic stages of various parasites. Okay, right. Let's bring our stuff here with us. Okay, then you can see the difference between the primordium of the strongyloid stericolaris versus primordium of the hookworm, which is really inconspicuous or not really prominent. The next roundworm is called strongyloid stericolaris. It is also called threadworm as well. It's called threadworm. It can be found in different forms. That's why it is called strongyloid. I think that's why it is called strongyloid, because it has a very strong way of living. It has very many life parts or life stages. So strongyloid stericolaris can persist in host for decades after initial infection, and may progress to hyperinfection if the host is immunocompromised. Strongyloid is also associated with what we call hyperinfection. So clinical manifestations include even though many people with the strongyloid stericolaris infection are asymptomatic, but patients may exhibit fever, nausea, and vomiting, and sharp stabbing pains that resemble the ulcers of the stomach in most cases. So chronic mild diarrhea may also present, and you find eosinophilia is also another sign here. Unlike hookworms, however, strongyloid stericolaris larvae penetration of the skin does not cause any pain, and migration through the lungs rarely elicit pneumonitis. It doesn't cause actual pneumonitis or lung infection or lung inflammation. So the patients actually may experience wheezing and mild cough. So immunocompromised patient, however, on corticosteroids with lymphoma malignancy or other conditions that can cause T cell depletion, they will develop serious infections. Of course, that is what we call disseminated strongyloidiasis or hyperinfection. If someone is on corticosteroids, or if someone is on chemotherapy and some other conditions associated with the lymphocyte depletion like AIDS, they are going to experience disseminated strongyloiditis, which is called hyperinfection of the strongyloid stericularis. So in this group of people, large numbers of the filariform larvae develop in the intestine in what you call autoinfection cycle and migrate from the intestine into the lungs and other organs of the body, for example, liver, heart, and CNS, which cause fulminant or fulminating and fetal infection. So that's what we call hyperinfection of the strongyloid stericularis. Other manifestations include secondary bacterial infections, which occur as a result of massive larval migration in the patient with the disseminated strongyloiditis. So the mortality rate in this case is very high. So mortality rate with the strongyloid stericularis hyperinfection in immunocompromised patients is over 80%. So, and the cause of infection and the cause of death is normally associated with respiratory failure complications. So life cycle, which is very complex, of strongyloid stericularis, it is very, very complex. Let's just look at it a bit. So life cycle of this strongyloid stericularis is it takes about 3 phases, which is direct, which is similar to the hookworms, but also indirect, which involves a free living stage, and as well as autoinfection, which we call, of course, hyperinfection of these parasites. So the first cycle is what we call direct. And direct, the fertile egg will hatch in the intestine and develop into the labidiform larvae, of course, which is non-infectious, and the larvae is passed in stool, right? When this larvae reaches soil outside in environment, this larvae is going to develop and become filariform larvae, which will then be infective to humans. So this is what we call direct life cycle. So this, of course, the larvae are going to penetrate human through the skin without causing actually serious inflammation of the skin. Once the larvae has penetrated the skin, they just enter blood, and then they break out from capillaries and they reach lungs and migrate up to the bronchial tree and then over the epiglottis, and then they will be swallowed and enter digestive tract, where they mature and become adult worms. So that's how direct life cycle is, almost the same life cycle as hookworms, right? It resembles hookworms. So only the difference is penetration through the skin does not cause serious inflammation. So the second type of life cycle with the strongyloid stericularis is what you call indirect life cycle, of course, which include a free living male and female labidiform larvae, right? Labidiform larvae will just develop in the soil and become free living male and female. They become like snakes, right? Outside in the environment. And when they are there in environments like snakes, they produce eggs. At any point, the free living life cycle may just revert back and result in the production of infective filariform larvae. For example, those eggs, they will hatch, and then labidiform larvae will also grow and become filariform larvae, and those ones are the ones to penetrate human skins. So you can see that is just free living, but which is going to end up causing infective life cycle, like what we see in direct. The last life cycle type is what you call autoinfective life cycle, which just allow initial infection to persist at low levels for years, and then is the underlying cause of hyperinfection. You know, hyperinfection is when those larvae penetrate the skin and penetrate the intestine and invade other part of the body. In this life cycle, of course, labidiform larvae, rather than being passed in stool, they will develop and become filariform larvae in the intestine, of course. And then those filariform larvae, they are going to penetrate blood circulation, and then in some cases they will return to the intestine to develop into adults. That is just what is happening. They don't need to go outside, but it is like autoinfection, because labidiform larvae, which are supposed to be passed in stool, they are going to mature and become filariform larvae. And those filariform larvae, they are going to penetrate the skin in the same patient, and then they would return back to, they're going to penetrate the intestine, and they circulate in the body until they return back to the intestine to mature and become adults. That is how this life cycle works. And lab diagnosis is just, as you can see, there's nothing like egg, right? There's nothing like egg. It's not like hookworms. There's nothing like eggs. What you are going to diagnose for Strongyloides cercoralis is only labidiform larvae. That is the diagnostic stage of it, and it will possess a short buccal capsule, large bulb in the esophagus, and prominent genital primordium, which is located in its posterior half to the posterior third of the labidiform larvae. So I think I've already demonstrated how it looks like, what you call primordium, which is located almost half the posterior third of this worm. So this is Strongyloides cercoralis. Only the difference that you are going to notice here, it is the length of. We are going to differentiate between Strongyloides cercoralis and hookworms labidiform larvae. So for Strongyloides cercoralis, they will possess short buccal cavity, buccal capsule, but they will have a very prominent genitorial primordium. So of course, as opposed to the labidiform larvae of the hookworms with the very, very inconspicuous genitorial primordium, but very long buccal cavity. So that's how you can actually differentiate. So the eggs are not seen. In fact, the eggs is not easy to see them in stool, but only in cases of severe diarrhea. So those eggs, they will look like the eggs of hookworms with a very thin shell and even sometimes segmented. Filariform larvae has a knotted tail and has esophageal to intestinal ratio with 1:1, and Filariform larvae may be identified in the sputum of patient with the hyperinfection, because Filariform larvae is just migrating all over the body, especially reaching the lungs, and you could find them in the sputum. So if clinical manifestations suggest Strongyloides cercoralis, but multiple stool specimens are not giving positive results, you can perform duodenal aspirates or biopsy in order to guide diagnosis. So, and then treatment include albendazole or just ivermectin to treat the infection. Finally, we have just a few tissue and blood roundworms. So the one that we normally know as a tissue roundworm is what you call Trichinella spiralis. It is a spiral infection. Trichinella spiralis is associated with the trichinosis. This is infection of the muscle tissue with the larvae form of the Trichinella spiralis, a helminth whose adult stage live in the human intestine. So the life cycle of Trichinella spiralis, it just involves eating undercooked meat, because this is a tissue infection, which especially pork meat, which contain larvae forms of Trichinella spiralis, and larvae are just released from the tissue capsule in the intestine and mature, then become adults. So female produce live-born larvae that penetrate the intestinal wall and then enter circulation and then is carried out throughout the body. So that is just a direct life cycle of the Trichinella spiralis. So once those larvae enter the striated muscles, for example, of course, striated muscle can be skeletal muscles as well as cardiac muscles. They are all striated. They can begin a maturation cycle, and that is completed in 1 month. The larvae coil and become encapsulated in the tissue, although larvae remains viable for many years, but eventually the capsule calcify and then the larvae will die in the tissue. So that's why you find them. You find the larvae in the tissue. That's where you will demonstrate them. So when actually the larvae mature in the intestine after being consumed in the meat, they don't like to live in the intestine. They will just penetrate the tissue, intestine wall, and enter blood circulation, and then of course they are carried to the striated mass where they will just grow and then they encapsulate, right? So manifestations include some few symptoms like diarrhea and abdominal discomfort, especially during intestinal phase before tissue phase. And most symptoms will occur just during migration and encapsulation periods in the tissue. So common symptoms, of course, include periorbital edema, fever, muscular pains, and tenderness of the muscles, headache, and also weakness in the body when these larvae are being encapsulated. So muscle enzymes level may also be elevated. For example, of course, you find creatine kinase being elevated. That is example. So splinter hemorrhage will happen beneath the nail of these patients, and also eosinophilia is very, very high. So lab diagnosis for Trichinosis spinaris, of course, it is very difficult to recover adults or larvae in the stool specimen, because once the larvae are in intestine, they just migrate very quickly to the tissues, and the diagnosis is actually made on clinical symptoms as well as patient history, and also biopsy can be taken, which is a biopsy of muscle tissue, which is taken then to observe encapsulated coiled larvae in the tissue, and that is going to be definitive diagnostic methods. You can see them here. You can see this is encapsulated coiled larvae right in the tissue, which is going to be definitive diagnostic criteria. And this is, of course, hematoxin and eosin stain of the tissue. So finally, filarial larvae. So they are just like, filarial worms. Filarial worms. There are just very few of them. You have what you call Wuchereria bancrofti. We have Brugia malai. So this is the last filarial worms. We have also Onchocerca vivaris, and finally we have lower. So those are actually the filarial worms. So filarial worms are also roundworms of the blood and tissues. So they are actually seen causing disease. But apart from these pathogenic ones, we have other non-pathogenic ones that can confuse you, including, of course, Mansonella ozaldi, Mansonella persistans, as well as Mansonella streptococcus. They can also be seen on the clinical specimen, but they are not associated with infections. So these adult roundworms gave birth to live-born larvae, which are called microfilaria, right? And identification of the various species depends on the morphology of the microfilaria, so as well as periodicity, which means microfilaria migration, which time of the migration, as well as location of the worm in the host. So depending on the location, we can also predict which species. So the morphology of the microfilaria, which is very important for us to characterize or to diagnose the microfilaria, or of course the roundworm in general, we have to look at the presence of or absence of the sheet, which is the remnant of the egg from which larvae will hatch. That is the sheet. That is the remnant, or the remain of the egg from which the larvae will hatch. That is what we call sheet on the larvae. And also the second thing that you have to look at is the presence and arrangement of nuclei in the tail of the larvae. So you can then say that maybe there is a presence or absence of sheet, but sometimes also we can see nuclei are extending to the tip of the tail, or sometimes they are not extending to the tip of the tail. Then you can report in that way. In general, adults may just live in human lymphatics, muscle, or connective tissues, and mature female produce microfilaria that are infective stage for the insect during the insect blood meal. And of course, those microfilaria, once ingested, they penetrate insect gut wall and develop into infective third stage, which is called filariform larvae. So that is the thing. When female produce microfilaria, they are just infective for the insect. So that's what insect will take up in the meal, of course, the blood meal, and of course, filaria microfilaria are going to migrate to become filariform larvae, and these larvae will just enter insect proboscis. So proboscis of the insect is like a sucking disc. It's like mouth of the larvae. I mean of the insect. That's what you call what used to suck blood. It's called the proboscis. So then, in the proboscis, those larvae, the filariform larvae, they are going to be introduced into human during feeding of the mosquito, of the insect. Of course, that will enter human blood circulation. So the first one we know here, it is what we call Filarial bancrofti, which can cause Bancroftian filariasis, which is also called elephantiasis. So Filarial bancrofti is actually found in tropical regions, and the insect vector which is associated is a mosquito which is called Culex or Aedes, and the Filarial worms will live in the lymphatic and lymph nodes, and of course, especially those one in the lower extremities. That's where Filarial worms live, with Filarial bancrofti adults, lymphatics and lymph nodes of the extremities, especially lower extremities. So the presence of the adults will initiate some response, immunological response, which include, of course, cellular reactions, edema, and hyperplasia, and even granulomatous reaction will also occur with fibrous tissue around the dead worms. So this is going to cause cause increased hydrostatic pressure with subsequent leakage of fluid into the surrounding tissue where this adult worm resides. And during this period, the patient is going to experience various symptoms, including fever, headache, chill, as well as swellings, redness, and lymphangitis, and even primary sites in the male and female genitalia and extremities. So elephantiasis is a debilitating and deforming complication which occur in 10% of those infections, and chronic obstruction in the lymphatic flow results in lymphatic varus fibrosis, proliferation of dermal and connective tissue, as well as enlarged area is going to be hard and leathery appearance. That's what we call elephantiasis. So you know how to look like, what you call Bancroftian disease, which is also elephantiasis. So diagnosis of Filarial bancrofti is going to be the examination of the worm, of the larvae, of course, microfilaria, the presence of microfilaria at midnight in the blood specimen, most commonly, and the blood may be examined immediately for live microfilaria, or may be pulled on a slide and stained. So filtration up to 5 ml of blood through a 5 micrometer nucleopole filter can detect light infections. When the infection is not really high, so we can just filtrate blood in order to concentrate microfilaria. So microfilaria of Filarial bancrofti are sheeted. Of course, we find a sheet on them, and the nuclei don't extend to the end of the tail or to the tip of the tail. So that is a conclusive diagnosis of microfilaria of Filarial bancrofti. They are sheeted and the nuclei don't extend to the tip of the tail. So that is it. And then apart from that, we have also so this is how to look like. You can see these are the sheeted. This is the sheet, right? And you can see the tail is very long to this area, but of course the nuclei that are present, as you can see them inside, they don't extend to the tip of the tail. So you can see these ones are just white blood cells. So Blugia marai is also another filarial worm. So you find the transmission is by mosquito of the genera Mansonia, Anopheles, and Aedes, and pathology is just the same as those seen in Wucheria bancrofti, but the distinguishing characteristic is just the microfilaria, which is going to show the presence of the sheath at the end of the tail, and the arrangement of tail nuclei. The nuclei extend to the tip, but a space separates the two terminal nuclei. It is almost the same as Wucheria bancrofti microfilaria, but the sheet is there. It is sheeted, but the arrangement of tail nuclei is different. So the nuclei extend to the tip of the tail, unlike Wucheria bancrofti, because Wucheria does not extend, but there is a space between two terminal nuclei, which is going to give like somehow a gap between the two nuclei, which can confuse you, but still the last one extends to the tip of the tail. So lower is also the another among them. So lower, it is most commonly the eye worm, and it is carried by the fly vector, which is called a chrysops. So adult will live up to 15 years in human and migrate through the subcutaneous tissue, causing temporal inflammation reactions, which is called the calabar swelling. So calabar swelling is associated with the lower. So characteristic of the swelling that can cause some pains, which is called the pruritus, and only to reappear in other part of the body after some time. So the adult worm can often be seen as it migrates across the surface of the eye. So lower, because it is eye infection, you can see it just migrating slowly across the surface of the eye, especially the white of the eye. And diagnosis can be based on the presence of calabar swelling and or of the adult worm in the conjunctiva of the eye. So conjunctiva of the eye, you will see the adult worm just migrating slowly. So, but microfilaria can be seen in the blood specimen as well if it is taken during the day. That is when you can see it during the day. Unlike Wucheria, you have to collect at night. So here you have to collect during the day, and especially around noon when the migration is high, right? So the microfilaria of the lower is sheeted, and the nuclei they extend to the tip of the tail. So all of them so far, they are all sheeted, and the nuclei extend to the tip of the tail with Blugia marai as well as lower, but Wucheria, they don't extend to the tip of the tail. And the final one is called Onchocerca vivaris. There's also another filarial worm. It can cause problems including onchocercosis as well as rival blindness. So the Onchocerca is found in various parts of the world, especially Africa and South and Central America, and it is transmitted by Simurium, a black fly. This is the bite of this fly which transmit it. So adult worms are encapsulated, and you find they are encapsulated in fibrous tumors in humans, and you find those are called nodules in subcutaneous tissues of the skin, especially skin and subcutaneous tissues, and you find those nodules, but sometimes they are not found in blood and lymphatic fluids. So then it means that nodule is the site of specimen, is the base specimen. So they can live in nodule and be mature and become very large, up to 25 millimeter, and they are the result of inflammation and the granulomatous reaction around the worm. So those are the nodules of these worms. So they are subnodular or nodular worms. So you just have to remove the nodule, you'll be able to see them like this. So you can see they are encapsulated in the nodules. You can see them inside these capsule, you find so many Onchocerca vivaris. So blindness is the most complication which result when microfilaria correct in the cornea of the eye and the iris and cause hemorrhage. Keratitis. So keratitis is also infection of the eye, keratitis, and atrophy of the iris. So diagnosis of Onchocerca, it is most commonly to look at the presence of the nodule and remove it. So, and microscopic identification of microfilaria. So diagnostic method is just very simple. It is the skin snip, in which of course we have to slice the skin. Very small slice of the skin is collected, and then that small slice of the skin is going to be placed on a saline mount. So microfilaria can be seen, and they are not sheeted, and the nuclei don't extend to the tip of the tail. So this is on the only this is the only Filarial worm so far that is not sheeted, but also the other thing is that the nuclei are there, but they don't extend to the tip of the tail. So so Mansonera species, these are not actually not infective, but they can also confuse because of their characteristics. So in fact, we look at Mansonella ozardi and Mansonella streptococcus as well as Mansonella persistens. They are not found with infection, but also their microfilaria can be seen, and especially microfilaria of Mansonella streptococcus can be found on the skin, and they are not sheeted, and they have nuclei that extend to the end of what we call Sheffield cloak tail of the Mansonella streptococcus. But microfilaria of Mansonella ozardi and persistent can be found not in the skin but in the blood, and they are not sheeted at all. But Mansonella ozardi microfilaria, they will have tail with the nuclei that don't extend to the tip of the tail, but the nuclei of the Mansonella persistens, they extend to the tip of the tail. So thank you so much for your time.